Hello and welcome back to another CPD talk. So again, like the previous CPD talks, all of the information regarding the documents used will be in the description box below. There aren't any associated websites or worksheets to do alongside this presentation, so it's an easy sit back and listen one. Today we're going to be discussing grouping anomalies, how we should investigate them and when should we send them to the NHS-BT. What we're going to be covering is an overview of normal routine blood grouping. It's going to be very quick because there's going to be a different presentation on blood grouping. If you're not 100% confident with routine blood grouping, I do not recommend this presentation for you. It's more in depth and it could become confusing. We're then going to go through the types of grouping anomalies that can occur, and this is going to include reverse grouping anomalies and forward grouping anomalies. So, routine blood grouping. You can see here we have a table of all of the normal blood groups that you would expect. The bits in the red box is where we are testing for the antigen present on the patient's red blood cells. The bit in the yellow box is where we're testing for the antibodies present in the patient's plasma. You can see here that the normal reaction strength we'd be expecting is a 4+ for a positive reaction. Sometimes it is acceptable to have weaker reactions, but we'll go through when it is not acceptable. And there is a control well as well. This should always be negative for the test to be acceptable. So, the types of grouping anomalies that can occur. When performing grouping investigations, there are several reactions that can be obtained that do not follow the normal patterns. So those would be the patterns that were up on screen previously. When this happens, it is really important that we investigate this fully in-house to ensure that if the patient requires blood urgently, we can give it to them. Also, because sometimes the investigation that we do in-house is enough, so it wouldn't actually need sending away from the NHS-BT. So we're saving money for the NHS by not sending it away unless it's needed. So sometimes these changes or anomalies are down to something as simple as age or drug therapy, and it won't affect at all what blood group that they are or the blood that they require. However, occasionally you will have some grouping anomalies which will completely change what blood that patient requires, even making it so that group O blood is not acceptable. So we're going to go through all of the more common grouping anomalies that you will come across in the lab. So here I have an example of what some grouping anomalies look like. If you want to take this opportunity to pause it and actually go through the ones shown on this slide and see if you can guess what you think the anomaly is, or see if you know what investigations you would do, then please feel free. Obviously that would be a great thing to reflect upon, whether or not you're right or wrong. In general, what we're really going to be looking at is we're going to split it up into two different sections. We're going to look at the forward grouping anomalies, so those are the ones where we're looking at the antigens on the patient's red blood cells, and the reverse grouping, and that's the antibodies. We're going to start off with reverse grouping because that's the more common issue that you're going to come across, and it's the one that requires more investigation in-house than the forward group. So going through the table here, the first one, you can see the forward group looks like an A negative. However, it's weak in the A. The reverse group would indicate that the patient is an O. So you'll see why there's an issue there. The second one is just pan-reactively positive, so the control well is positive, so it's not an acceptable test. The third one looks like it should be a B negative, but has no reverse group. The fourth one has weak reactions in the D, so it should be an AB, possibly a positive, but it's only a 2+. Next, you've got one that's got weak reactions in the forward group and in the reverse group. Then you've got some mixed field reactions, so they could be an A positive or they could be an O negative with a weak reverse group. We need to investigate. And finally, you can see you've got mixed field reactions in the reverse group. So in the forward group, it looks like an A negative. In the reverse group, it could be an A or it could be an O, depending on how you interpret that mixed field. So you can see why it's important for us to actually work out what blood group they are, because there are several different answers based on those grouping results. So we're going to start, as I said, with the reverse grouping anomalies. In general, grouping anomalies in the reverse group consist of unexpected positive reactions or unexpected negative reactions. Both of these can occur for reasons that can change the blood group that you would give the patient, or just due to simple interferences that would lead to no changes in the blood group selected. Whenever you come across a grouping anomaly, you should always check the patient's history. Checking the patient's history can save you a lot of hassle. In general, people will have already done investigations if they're a known patient, and there should be a cause for the issues. So either it can give you an indication as to what investigations you need to do, or it could indicate that you don't need to do any. So it's always worthwhile checking the history and seeing whether anything is actually required from you. So we're going to start with unexpected positive reactions. These can occur as a result of warm agglutinins, room temperature antibodies, an A2 patient with an anti-A1, strongly DAT positive patients, or something as simple as sample, machine, or reagent errors. It's always important to remember that sometimes it is just that the machine isn't pipetting something, or there's been a splash and you've ended up with two reagents mixed together. Always make sure that your analyzer is working correctly. So how would we investigate these? We're going to assume for this presentation that the analyzer is working perfectly fine, so we don't need to investigate that. So, as I said, the first thing you do, check the patient's history. If it's a patient that has a known history of grouping anomalies, then check what the person's done before you and see whether further investigation is required, and it will give you an indication of how to proceed. If it's unknown, then you have to slowly eliminate each of the possible causes for this anomaly. In general, this means that you start by warming the samples. So here you're looking for warm agglutination. This means that the patient's antibodies are agglutinating the reagent red blood cells at room temperature, and by warming the sample, this should stop this agglutination. It means that any agglutination that's happening at room temperature is obviously not clinically significant because it would not happen in the body. When you have a patient that is reacting as a result of warm agglutination, the way that this looks in the microtubule is very different to a normal positive result. It takes some experience to know what you're looking at, but once you've seen it a couple of times, majoritively you would be able to recognize it. So if you suspect this, the first thing is to warm the sample, warm the reagents, do a manual card group. If the control well is also positive, you may need to warm wash the patient's red blood cells, but obviously if it's just the reverse group, then you're using plasma, so you can't really do much about that in-house. If you warm the sample and there's no change, and you think it is due to the warm agglutination, then you can send it away to the NHSBT and they should be able to get you a blood group. If you're not sure that it's due to the warm agglutination, then you should run an extended full group. Now, we do not have this facility at our site, but the principle of an extended tube group is as follows. So you would set up the same forward group as you would normally. So you'd have the anti-A, anti-B, anti-AB, etc. But with the reverse group, you would include extra cells. So as well as the A1 and B cells, you would also include O cells and A2 cells. Then, based on the results you get, would indicate the next testing you would do. So you can see here in this table, the first result, the patient is pan-reactive with all of the reverse group. That indicates that it's possibly to do with a DAT positive patient, or maybe a room temperature antibody. In the second set of results, you can see here that the patient is negative with the A2 and negative with the O cells. This indicates that this patient is having a specific reaction with the A1 cells. So we'll go through how to do all of that. Now, if you get the first result, run a DAT. If this is positive, then you need to send the sample away for testing by NHSBT, as obviously it's interfering with the results. There's not really much else you can do in-house. If the DAT is negative, however, then you might want to investigate a room temperature antibody. So, on occasion you'll have an antibody, the most commonly known one would be anti-M, that reacts best at room temperature, and this can interfere with the blood grouping results. You probably still need to send away the sample to get a clear blood group result, but you could do a room temperature panel on the sample to see whether or not you could identify the antibody present. And obviously that just gives you a bit more information for the patient's record and for the selection of blood. If you've got the second result, it could be an A2 patient with an anti-A1. This would only be applicable if the patient is either group A or group AB in the forward group. If they're group O or group B, it doesn't make any difference. If this is suspected, then you need to perform a phenotype to be able to confirm this. Once you've determined the cause, how would you proceed? If you've managed to resolve the grouping anomaly by warming it, for example, then you don't need to send it away. You can update the blood group on the LIMS system and you'll be able to give the patient their own blood group. If you haven't been able to resolve it, then it would need sending away. If the patient appears to have an anti-A1, it should be sent to the NHSBT to confirm. The patient must have group O red blood cells in the meantime. If you give them group A, these red blood cells will be group A1, so they could have a reaction if they do have the antibody to A1. If you cannot resolve the anomaly in any way, again, then the patient should have group O red blood cells. Obviously, you should update the LIMS system with all of the testing that you've done. Just gives a bit more information to the next person who comes along to try and test the sample. Unexpected negative reactions. These tend to occur more often in natural occurring situations. For example, patients that are older, patients on some drug treatments, patients less than 4 months of age. These shouldn't be tested for a reverse group anyway, but if they are, no investigation would be required if they were missing parts of it. Allo-BMT converting to a new blood group, or cold agglutinins. However, it's just as important as with the unexpected positive reactions to properly investigate these results. Again, check the patient's history. If they're known to have a weaker or missing grouping reaction and their correct blood group has been confirmed at least twice in the past, then no further action is required. You just need to add in the relevant comments based on your SOPs that will exclude them from electronic issue as it's had to be manually edited. If they're a bone marrow transplant patient and they're known for this, then their group should be recorded as unknown. Again, the comments that your SOP asks for added in, and only group O red blood cells should be given. If there is no history of the patient having issues previously, then we would investigate. The main investigation that you would perform is to do a tube group at room temperature to see if you can detect any agglutination where the analyzer could not. If this does not work, then a tube group can be performed at 4 degrees. This helps because the antibodies that we are trying to detect are IgM, and their optimal temperature is between 4 and 25 degrees, depending on the antibody. If this still does not work, then the reverse group can be checked microscopically for agglutination. If this does work, then the blood group can be updated, as it's manually edited, a serological cross-match would be required. However, group-specific blood could be issued. If it does not work and you still can't obtain the correct reverse group, then you'd have to send it to the NHSBT for confirmation. Forward grouping anomalies. It's rarer to see forward grouping anomalies. Most of these will be due to clinical interventions, so bone marrow transplant again, transfusions with the incorrect blood groups, or analyzer sampling issues. On occasion, there will be weaker reactions on the forward groups. This is normally due to there not being as many antigen sites present on the patient red blood cells. However, it can be due to variants. So a variant or weak D reactions, old people, again less than 4 months old, some drugs, A2 patients. We're going to start with mixed field reactions, however. Mixed field reactions are almost always due to the patient's clinical history. This is normally a transfusion of emergency red blood cells when the patient is a different blood group. It can also be due to a bone marrow transplant. If the patient has no history of either of these on our system, ensure that you ring the ward or clinician looking after that patient to check that the patient has not been transferred from somewhere else. If they have had a transfusion of their own blood group, for example, an A positive patient, but are still coming up mixed field, perhaps in the RH, then it might be worthwhile contacting the NHS BT, as they do sometimes have blood that has been donated by a weak or variant patient that we could have picked up as being negative. There's some more information on that in the Transfusion Quarterly Update, which should be coming out in the next month or so. Finally, remember interferences such as fibrin may give false positives or mixed field reactions, so just make sure that the sample is of good quality. If you cannot find a cause for the mixed field reaction, it's always worth asking for a repeat sample. As I said previously, sometimes you do get samples that have issues with them. And if it's not an issue with the sample, it might be a wrong blood in tube. If you still cannot confirm, then the sample would need to be sent away and the patient given group O until the blood group is confirmed. Unexpected negative reactions. This is normally due to an analyzer issue, so not sampling correctly, not pipetting things into the correct areas, the sample having a clot, or reagents not functioning as expected. Make sure you check the sample, check the analyzer, rerun, and ask for a repeat. Double check that it isn't the reverse group that has the issues. Unexpected blood groups. So this is the most important grouping anomaly for the forward group. Variant blood groups are of great importance as these normally require different groups of red blood cells to be transfused. There are a few variant blood groups that you will come across. We already discussed an A2 patient. So the other thing to be wary of with an A2 patient is normally their reaction in the forward group with the anti-A will be weaker than expected. In this section, however, I'm going to give a quick overview of the Bombay group. Please note that there is going to be a separate presentation on Bombay, so again, this is just going to be a very quick zip through. The Bombay blood group lacks the H antigen. This means that they appear to be a group O patient, as the A and B antigens could not be created. They can create anti-H, meaning that all routine units of blood would be incompatible, even group O. So if they look like a group O, how would we even know that they were Bombay? We would know by looking at the antibody screening results. People who are Bombay would present as follows. They would have a pan-reactive antibody screening panel, both in IAT and enzyme. They would have a negative DAT and autocontrol. Any cross-match that you attempted would be incompatible. And normally with Bombay, you're looking at someone who is of Indian origin. If you do get these results, you would need to send the sample away for further testing at the NHSBT. But be wary, it might not be a Bombay. This patient could also present with an antibody to a high incidence antigen, giving all of the same reactions. If you do have a patient that you suspect is Bombay or has an antibody to a high incidence antigen and you need blood for the patient, you would need to discuss this with the NHSBT. Quite often with the antibodies that are clinically significant in these scenarios, the NHSBT has blood frozen on site. So in an emergency, there would be blood that we could get that would be suitable for the patient. Finally, forward group weak reactions. If you have a weak reaction in the forward group, the investigation will depend on what is weak and how weak it is. If you have a weakly positive reaction in the RHD, then this could indicate that patient either has a weak D antigen expression or a variant/partial D. These results are of the most importance to patients that are either of childbearing age, likely to be multiply transfused, or who are children. This is because if a patient has a weak D expression, then they cannot produce allo-anti-D. However, if they have a variant or partial expression, then they can. So if pregnant, would need prophylactic anti-D. So you can see why it is important to distinguish between the two. In-house, our current policy is that if a patient who is of childbearing age or is a child has a weak RHD result, they will need to be sent away to the NHSBT for further testing. However, if they're male or above childbearing age, then we would just call them an RHD positive patient. If you get other weak reactions in the forward group and the reverse group is as expected, then these are generally not investigated. While these can be due to variants, they are normally just due to a reduction in antigen sites. If you do get a weak forward group and you suspect a variant, for example, an A2, then please discuss it with a senior member of the team. So, an overview. We've gone through a lot of information here quite quickly. This was only meant to be a presentation to go over some of the possible grouping anomalies. There are always more out there. There are many possible causes for abnormal grouping results, but we must always do our best to resolve these internally before sending them away. And we should never just authorise any results with an anomaly. These anomalies can affect what blood a patient is given, and that is why it is so important. Thank you all for watching. I look forward to our next CPD talk, and as always, please feel free to contact myself or any of the other seniors if you need any advice.